category of oral surgery, and Dr. Balaji, you know, the most eminent oral surgeon which I've seen. For him, this surgery is absolutely child's play. He can do this surgery blindfolded, I know that. But then it's not the surgery we are talking about, brother, today. We are going to talk about the human amniotic membrane and what role it plays in the healing of the bony lesion once we create the surgery, which is created after the surgery. So, you know, endodontic treatment, the conventional endodontic treatment has been going on for many, many years. Surgery has been attempted in between for some cases, but surgery actually has taken a lead role. It's quite prominent now, and a lot of cases are being treated by the endodontic surgery. In the department at King George's, we treat almost maybe 15 to 20 cases by surgery in a month. And what cases are to be treated by surgery? What we see from we have assumed from the clinical scene, the lesions which are very large, lesions which are very old, maybe 10 years old, and trauma which has happened 10 years ago, which is involving more than 2 teeth or 3 teeth or 4 teeth. Such cases are better to be treated by surgery than attempting endodontics, conventional, and that treatment going on for months and months and not healing. Also, certain cases where there is a persistent pus discharge, there is a sinus formation which is not healing, even after treatment, endodontic treatment, and certain cases where endodontic treatment just cannot be attempted. So periapical surgery or the endodontic surgery we are doing in such cases. And what you can see is that this is what we normally do, the line of treatment. We change from endodontic treatment to endodontic retreatment to surgical endodontic treatment. So this is what the line we normally take. But what we have seen today, that surgical endodontic treatment can be the first line of treatment also in many cases, and it should be the first line of treatment. In such cases, you see where there is a poor endodontic treatment has been done, surgical intervention may be done, may not be done, but it is not really the need here, because it does not mean that once any poor endodontic treatment has been done, then you go for the surgery. That is not the idea. And as you see over the years, a lot of things have changed, a lot of magnifications have come, micro-instruments have come, regeneration concepts have come, and grafts have come. The natural and synthetic grafts have come. And this is what we are trying to put in today, the use of the human amniotic membrane as a graft, as a tissue graft, together with the periapical surgery and together with the synthetic bone healing agents. The success rate is almost 90% to 95%. You see, whatever we use for periapical surgery, any graft or any tissue, whatever we will use, and then we can say that this is nice, this is doing well, this is not doing well. But we must understand that periapical healing does not depend only on the material used. It depends on many other factors. And these are the factors on which the success of your surgery will depend. It depends on the tooth position, on the type of the lesion, on the endodontic quality, of the size of the lesion. It will also depend on the clinical skill, which is most important. If the clinician leaves some pathology behind, does not clean the bony cavity properly, or does not attempt the surgery well, it is not going to have a good prognosis. The clinical skill in dentistry as such, the clinical skill is the most important factor. Notwithstanding the material, notwithstanding the instruments, notwithstanding any other factor, the most important factor is the clinical skill. How well your hands can do it, the job which you are attempting to do. There is a scientific basis for everything, whether surgery or non-surgery. There is a scientific basis which you are taught in these books by these teachers. But if you are told that this has to be done like this, but your hands are not able to do it, then it's of no use really. So it's your skill which you have to develop. Some people have natural skill. They are naturally gifted, while some people have to develop it. You have to see whether you are gifted or not. So one of the factors, is the root end filling. Because many times, Brother Bala, in endodontic surgery, what we have been seeing in our institution, when we refer it to the oral surgeons, or some cases are done by the oral surgery people, there is a failure. There's a high rate of failure. After 4 years, 5 years, the pathology comes back, and then the patient is sent to us to do the periapical surgery. The reason for failure for a periapical surgery is a case where no root end filling is done after the surgery. It's a major reason for failure. Every case, not now what we were doing, we were sending one endodontist resident to the oral surgery people in their OT. They used to do the surgery, and these people used to do the root end filling. And then the combined effect gives a much, much better prognosis. Because if the root end filling is not done, then the failure is bound to happen. I can tell you, it is only a question of time. Because what is done is, the root tip is cut. And once the root tip is cut, the apical foramen is enlarged, which is a microscopic apical foramen originally. And once you cut it by 1 millimeter or 2 millimeter, the foramen size increases. There is percolation of fluid between the cavity, bony cavity, and the tooth, and that causes recurrence. So root end filling is most important. And then the use of grafts, which we are going to talk about, the HAM, which is the human amniotic membrane. These are the various root end filling materials used. And you see, this is the one which is most commonly used. It is the MTA, and it is amongst the practitioners one of the most commonly used. But I still feel that one of the best root end filling material is silver amalgam. Because the silver amalgam is metal, it needs a very small cavity to fill it. And the silver amalgam, it sets rather fast. And once it sets, it will not dislodge. MTA, you have to seal the cavity, you have to stitch the cavity without the material being, solidifying. The MTA takes a lot of time to set, and the cavity has to be stitched. You can't leave the flap open. And after stitching the flap, we really don't know what has happened to the MTA, whether it is still there, it has dissolved, it has set, or what it has happened. But MTA is the most commonly used. We use silver amalgam also, and it is very successful. But only thing is that silver amalgam has to be thoroughly cleaned and removed from the cavity, because if you leave a little bit of silver specks, that the radiograph will show specks of silver amalgam which do not look very nice. So these are the tissue grafts. There are various types of tissue grafts. The autografts, allografts, xenografts, and the allografts. This is what we have used. This is the PRF. We have been using the PRF, the platelet-rich fibrin, and this is the graft which is derived from the human beings. And there is this allograft, which is the human amniotic membrane. We have used both of them. We have in the study, one group has been given the platelets, the PRF, the other group has been given the human amniotic membrane, and we have seen the comparison. These are the various bone grafts. Those were the tissue grafts. And the bone graft which is used most commonly is the xenograft. And the xenograft, these are the various grafts. The autologous or the autogenous are these. The allografts are the ones which are from a human other than the one receiving the graft. And the xenografts is like the one at the bottom is the bioos. This is what has been used. It is the material which we normally use for periapical surgery, but this time we have used it together with these tissue grafts. Now we come to healing. So you see the healing part. There are two factors which we know. One is repair, one is healing. We are not looking for repair. We are looking actually for regeneration. We are looking for healing. And that's why we are trying to use the grafts, the tissue grafts, together with the allografts. Repair is by ingrowth of connective tissue into the bone space, and this is ideal, but it is not easily attainable. It is an invasive technique. Now, this is what the guided tissue regeneration is. It has been used for periodontal regenerative therapy. It has been now used in endodontic surgeries, and it has human amnion, membrane has been used in various other factors also in dentistry, but up till now it was not used for periapical surgery. So this is for the first time we have been using the human amniotic membrane for the surgery, for the healing of this. This is what the human amniotic membrane is from the placenta of the human being, but is it from some other human being? So it has been used successfully in ophthalmology, ENT, and plastic surgery, and dentistry being the latest. And this is its ability to form the scaffolds. That's why it has been tried. Ham in regeneration after periapical surgery are very few. It has not been used much. We have been one of the few to use it. Some other people have also used it. And this has been commonly used, the PRF, and this is, it has the regenerative potential of ham in the study. It is a very, very viable option, and PRF has been used. To assess the periapical healing, we have used the ultrasound and the color Dopplers. This is a method which gives a more accurate evaluation of the periapical healing. It is the image modality. And you see, why ultrasound? It can detect failures at a very early stage. It can also detect healing at a very early stage. Unlike the conventional radiography and the other steps, ultrasound we have used in other studies also, and color Dopplers. And it relies on the sound waves transmission, and it has an added advantage of zero radiation exposure to the patients. This was the objective. We want to see the ham and the PRF after endodontic surgery, how the healing takes place using the ultrasound imaging, and how the healing is seen by ultrasound and color Doppler is by seeing the change in the vascularity. As the bone heals, the area which was non-vascular starts becoming vascular. And as the vascularity increases, the velocity of the blood flow increases, it gives a significant sign that the healing is taking place and how much it has healed and how fast it has healed. So these were the two study groups, the amniotic membrane, and this is how the amniotic membrane, it is now commercially available from the Tata Memorial Hospital, Mumbai. You can get it in sachets. This is how it is, and this is used with this BioWash. We fill the cavity first with BioWash, and on the top we put the membrane. And you see, oh, this is very beautiful. This is one of the oldest schools in Lucknow, I can tell you. And it is known as the Lamartnia. And it was, this school, I will tell you, is 170 years old. And it is one of the most unique schools in the world, because the students of this school have fought with the British against the Indians. आप लोगों ने mutiny सुनी है, Gadar? Have you heard the Gadar mutiny of 1857? Oh, never mind. This is the time of the mutiny of 1857. And the students who were studying here at that time, they participated in the war. Many of them died, and their graves are there, their memorials are there in the school. This is the only school which has honored the school children with war memorials. And it was founded by a French general. His name is Claude Martin. That's why it's Lamartnia College. Claude Martin started this school. And the photographs you see on the right side are of General Claude Martin. So this is what it is. You see the cavity, it is prepared, and the hydroxyapatite graft is taken first, and the careful placement of the amniotic membrane over the hydroxyapatite on the third slide. This is how it is done surgically. And then the group 2, the same procedure. After that, the hydroxyapatite and the careful placement of the PRF. How the PRF is prepared, most of us know, but I tell you, it is an invasive procedure. The blood is taken out from the vein intravenously from the same patient, and then it is processed, and after processing, it is placed. It is pushed into a centrifugal machine, and then the PRF, which is a soft mass, is placed. So this is how the lesion surface area was calculated by the ultrasound, and The vascularity was measured in terms of the peak systolic velocity, the PSV. That is how the blood vessels are working. This is how it is. At the end of the six months, the outcome was dichotomized. And healing was denoted by the reduction in the size of the periapical lesion as measured over the sonogram and the increase in the arterial velocity. So obviously, once the lesion starts to heal, the lesion size will decrease, the velocity will increase. But this cannot be found out by any other means. It can be found out only by color Doppler and the ultrasound. What is the velocity? How is it increasing or is it not increasing? And that is how it is. And the persistent disease, if it is a failure, then obviously the causes of failures are also many. It's not only the use of these materials, there are many causes of failures also, which can be attributed. And this is how it is, though you will not be able to see well, but this is ultrasound with the color Doppler showing the placement of reference marker here for calculation of diameters across the lesions. This is the post-operative after 1 month, and this is after 6 months. These are the markers which are placed, which tell us the size of the lesion and tell us how the velocity is increasing of the arterial flow or not. This is what we have been talking. The ham without the burger, but the PRF and the HA hydroxyapatite, which have been used in the study. So what we found out in this was that initially, in the initial part of the healing, the amniotic membrane did work well, better than the PRF. It was giving better results. In the initial healing, the lesion was healing faster, and the lesion had more velocity. It could be seen here in the intergroup comparison showed no significant difference at 1 month and 3 months to follow up. That is what it was. Statistically significant difference has not been found out. In terms of percentage change of surface area, significant difference was found up to 3 months. So initial healing, the ham was doing much better than the PRF, but after all, after 6 months, no much statistical difference was seen. You see this slide again. This is again from Lucknow. This is the residency. This is the site of that mutiny which took place. This is the residency where the British Army used to stay, and this was surrounded by the Indian mercenaries during the mutiny with the British. British historians call it the mutiny. The Indian historians call it the first war of independence. That was in Mangal Pandey picture आई थी. I don't know whether you've seen it or not. It denotes they started in Meerut, and this war, the first war of independence in 1857, started in Lucknow. And this is the residency where the ruins are still there. My house and my bedroom window, incidentally, overlooks the residency. So it has been a good place. So this is the advantages. It has enhanced bone remodeling, osteogenesis and chondrogenesis. And because of the presence of collagen, laminin, fibronectin and elastin, it has a non-thermogenic and pro-apoptotic potential, which makes it an excellent candidate for periapical wound healing, hence used in the current study. Incidentally, I tell you, yesterday when I was coming, I was in Bangalore waiting for my next flight for 5 hours. There was a girl there who started talking to me, and I got to know that she's coming to Trivandrum for a scientific meet. And her topic for the scientific meet was the use of amniotic fluid for wound healing. So it was a good coincidence. And she said that she has found some good results, that the amniotic fluid can be used for wound healing. So we are using the amniotic membrane for the periapical healing. So this is what it is. It is its application has been well established in periodontal, oral and maxillofacial procedures, socket preservations, maxillomandibular reconstruction, implants, which Brother Balaji Subramaniam Balaji knows very well. Huh? You do a lot of such work? No? Yeah, you do big work, I know. And this is what the ham studies have been there. Some of the ham studies have been there. The use of ham in regenerative scaffold in non-vital teeth, use of ham as a pulpotomy agent in permanent teeth with irreversible pulpitis, use of ham with hydroxyapatite and interpositional graft in periapical surgery. So ham has been used, but first time we are using it as an adjunct to the hydroxyapatite and putting a layer of the amniotic membrane over that and seeing the healing. So PRF has these factors, HAM has the same factors. But if you see, there's a plus. These are additional factors which are present in HAM. And because of that, it gives a better response to healing and repair. And that is why it has a great potential in our field of endodontic surgery or in or maxillofacial surgery as such. So this is what it is. Amniotic membrane is readily available. It is from the human body, some other human body. It is cost effective, requires no special equipment, and has a simple placement technique. That is for sure. PRF is an invasive technique. We all know that. And it takes time. It takes a machine. You have to get that centrifugal machine to make the PRF. But we have bought also. And this is how the HAM is got. It is delivered by the Tata Memorial Hospital. People can get it commercially from Tata Memorial Hospital. This is what it looks like from the placenta, the human amniotic membrane. It is derived from here. But variety of regions make it, there's this thing. The baseline parameters are different for all patients. So this is a limitation. We cannot standardize everything in this study. And difference in the innate immunity also is there. So some things are not in our control. And that is why the healing may differ from here to there. The present study, the participants will explain the procedure of amniotic membrane and its placement in their jaws. The patient cannot be, not told that this is a membrane which is obtained from some other human body, some other human source. And many patients refuse to get it put. This also we have come to see. They don't say we don't want it because it's from some other human body. Not comfortable. So PRF was the only choice with them. And there is limitation of ultrasound also. It cannot penetrate certain areas, buccal plates. So these are some limitations. Follow-up is limited to a few months only because of the buccal bone starts to form later and Doppler waves stop to penetrate it, in which case other modalities must be relied. Color Doppler is also only for a certain specific time, not before or after that. And this is what we are thinking, that if there is a ultrasound available in the dental clinics, extraoral for use for dentistry, it may be very useful and very helpful. Need for a dental intraoral ultrasound probe may be the thing of the future, what we are thinking. So encouraging results of the human amniotic membrane provide a promising therapeutic alternative, that's for sure. But further large-scale and histological studies are needed to confirm this regeneration, the ideal goal of endodontic surgery. See, whatever we do for the patient, boys and girls, you must understand that what we are doing and what you will be doing, it is in the best in the interest of the patient. Do nothing in dentistry which is not in the interest of the patient. In the sense, don't lose the trust of the patient. Dentistry is based on the trust of the patient. If you have fever, if you have a broken bone, you go to a doctor, he will give you medicines. You will know your fever has gone or not, your illness has gone or not. If you have a broken arm, you go to an orthopedic, he will put something. You will know within 2 months your arm has healed or not and what he has done. But in dentistry, the patient knows nothing what you have done. He is completely trusting you. You say you are doing this, but if you do something else, he will not get to know. But don't lose the trust of the patient. Have certain, human values incorporated. There must be compassion. There must be, generosity. There must be sympathy. There must be empathy. These are the soft skills which you must develop in your profession if you want to succeed. Take the blessings of the patient and the elderly and your gurus, most important. That's how it is. You see, life is all about healing touch. It is the healing touch. Once you will incorporate these, what I told you, the empathy, the sympathy, the compassion, the generosity, the kindness, and you do the work in the right interest of the patient, you will get the healing touch, which not everybody will get. You will touch the patient, patient will heal. We have seen it, I have seen it for many, many years. Some people have the healing touch. And you see, where the disabilities and complexities are overlooked with the warmth of unconditional love. Love, which is unconditional. You see, the child, the mother without the arms, and the child is feeding the mother. It is unconditional love. And this you have to keep in your mind for your family, for your, your social surroundings. It's your unconditional love. Conditional love is all right. Everywhere it is conditional. You give me this, I'll give you that. That's all right. And you see, General Claude Martin again. So this General Claude Martin was in Tokyo that time. But this at the back is the administrative block of our King George's Medical University, which is 110 years old. See, life, my dear students, is meant to be enjoyed. Prime thing in life is to enjoy your life. And at the same time, do things in which you can, fall back and enjoy your life. You can't enjoy your life just by roaming here and there. Don't waste your time. Don't waste your energy. Take risks in life, my dear children. Take risks in life. Some risks in life have to be taken. You have to get ahead. Take risk. If you don't take risk, you don't get ahead. That's for sure. And the risk will give you the thrill. The thrill is needed for life. There is something I will like to show you, which is more enjoyable to me than this damn lecture. That's all right. I will show you that thing. Put on that, please. See this. And that is what I was telling you about. Put it on. Let the children see it. Oh, 5 minutes. I think already we have 5 minutes. See this. Have a look at this.
Hello, good morning. Welcome to Skydive Dubai. How are you?
Hello, good morning to you. I'm fine and very excited to go on this.
You're going to jump out of an airplane, yes?
Yes.
First time?
First time.
And you think it's a good idea?
Oh, excellent idea.
You ready?
Yeah, I'm ready too.
You met your instructor. Did you understand everything?
Yes, I'm with Reggie and he's from Romania and he looks an expert to me. He has told me everything.
You don't have any questions?
He was asking me, are you nervous? I said, no, I'm only excited.
Okay, let's do this then. Let's fly. Enjoy.
Let's do it. Good.
Hasim,
Yes.
how was that?
Oh, it was unbelievable.
Unbelievable, yeah?
Unbelievable.
You enjoyed it?
It's an experience of a lifetime which everybody must experience. Must try.
Are you going to do this again? What do you think?
Yes, of course.
Awesome. That's the spirit we want to see.
Yes.
Congratulations. Welcome to Skydive Dubai and hope to see you back here soon.
Thank you.
Well done.
And thank you, Reggie. Also. Thank you, ladies and gentlemen, for a patient hearing. Thank you. Questions? Yes, something anybody wants to ask me? The oral surgeons are here. Yes, who know the procedure better than me? Yes, please.
Yes. Sir, thank you very much for excellent presentation.
Mike.
So thank you very much for an excellent presentation. And so what I would like to know your comment on is whether if we don't use anything at all, like neither ham nor PRF, so what do you think as an endodontist will it give good results as well or not?
If you clean the cavity well, if you do the surgery well, and if you do the retrograde filling well, if you don't use anything, it will still heal well. It may only just take a little time longer. That's all. These are adjuncts which will help in healing faster. And maybe with many things which ingredients they have, they will ensure they promote more healing and more regeneration faster. But when these things were not there, surgery was still being done. The surgery ultimately depends on a good endodontic treatment with a good retrograde filling and a good periapical surgery. Brother Balaji will say something. I know. For him, these surgeries are not surgeries actually. He can do it blindfoldly, so he thinks it's all right. For us, it's a major thing, you see. So we are trying to do our best. Anything? Anybody?
Any other questions from the audience? So it was an excellent presentation. And I think it would be very useful to all the postgraduate students that they can continue research in this field. So,
ham is available commercially from the Tata Memorial Hospital, and it will be available from other sources also very soon. And PRF has to be, it's an invasive thing which you have to prepare by the chair side. So both the options are there, and I think their use will be there in much wider use will be there in time to come in dentistry. Not only in surgery, but in other treatments in dentistry. Yes, sir.
Thank you, Dr. Tikku. We use some amount of bone graft from TMCH, and it was fantastic to know that they have amniotic membrane also, which can be used. Thank you so much for your very out-of-the-box lecture, and I think the climax was fantastic. Just seeing that probably put my BP up by a few.
But I tell you, it took me
points.
6 hours to get my body back to normal.
So
It took 6 hours. You have diving, falling free like a stone from 15,000 feet. So the body reacts. Obviously, it's not used to it. It reacts by tachycardia, high BP,
Yes.
palpitation. It is normal, but it's all right. It gets all right.
thank you for such an inspirational
Thank you.
talk.
Thank you,
And,
boss.
it's very important that the trainees here and the youngsters learn that out-of-the-box thinking is also very important to empower our field and to grow in our field. Thank you so much, Dr.
Thank you very much. Thank you, ladies and gentlemen.
Thank you, sir. Thank you, madam. Now I invite the moderator, Elizabeth madam and Satish Kumar Pugalindi sir to give the certificate memento to Tikku sir. Now I invite Dr. S.M. Balaji sir and Anil Kohli sir to give certificates to the moderator, Elipsut Koshi madam and Satish Kumar sir. 3 to 3:30. We'll be on time. Mostly push it also. We'll finish it as soon as. Thank you, sir, and thank you, madam. Now, moving to the next session, we give.
Let's move to the next session. I'd like to invite our beloved Principal Sir, Dr. Alex Matthew Murpal Sir, to moderate the session for it. And he's done his undergraduate in the AP Shetty Memorial Institute of Dental Sciences at Mangalore University. He's passed with the first class, and he's done the PGs in the AP Shetty Memorial Dental Colleges in Mangalore, passed with the honors in University second rank. And he was doing with the research and fellowship with the Diet Laser, and he was the HOD of Oral Implantology and our beloved Principal Sir. I welcome you, sir, to this session to moderate this. And next upon, I call upon the Lambodran Sir. He's the second moderator of the session. He was currently working as a Vice Principal and Administrator and Professor in the Department of Prosthodontics, Meenakshi Ammal Dental College and Hospital in Chennai. Pursued his bachelor degree of Meenakshi Ammal Dental College in the year of 2006, completed his post-graduation in prosthodontics in 2010 from SRM University, and has an academic experience of 15 years. I welcome you, sir, for this moderating the session. And the speaker of this session was Jagjit Singh Dalilwal. I invite you, sir. He works at the Institute of Health Sciences, graduated dental degree in 1994 at Karnataka University in India, and same university was awarded him his master degree in periodontology in 1998. The United Kingdom government awarded him a renowned Commonwealth scholarship in 2002, which allowed him to pursue an MPhil at the Newcastle University. In 2017, he was graduated doctorate in craniofacial health sciences from the McGill University in Montreal, Canada. India Council of Medical Research granted as a Dalilwal a 6-month foreign fellowship for the biomedical scientists in 2011 to 2012. His research focused on oral implantology, periodontology, oral palliative care, and biofilm decontamination. I welcome you, sir, to engage this session, sir.
What about the slides? Okay, just to correct you, it is McGill University. It is not McGill. No, it's McGill University. Okay?
Can they check the AV? It's not come on the screen. Can you check it, please?
Good afternoon, everyone. And so thank you to those who have stayed on from my lecture. I think it's lunchtime probably, and yeah, so thank you very much for attending. And thank you to the chairpersons for chairing my session. And thank you to the organizers, especially Dr. Alex, for allowing me to present my study here. Thank you very much. And I'm very thankful to the organizing committee for organizing this very good conference in a remote city like this, and it's commendable. Thank you very much. And so coming to the title of my presentation, it was part of my PhD at McGill University in Canada. And so this is part of my PhD, not the whole. And so the title I have chosen today is monitoring osseointegration by measuring stability in implants for overdentures. Okay, I work at the PAPRSB Institute of Health Sciences, and PAPRSB stands for, it is the name of the princess of the Sultan of Brunei. So, Pangeran Anak Putri, Sadatul Bolkiah Institute of Health Sciences is the full name. So here you can see our Institute of Health Sciences, and then this is the extension building. So there's an extension building, and at the back you can see the South China Sea. So it's a beautiful place to work, and so we are privileged to be able to work in University Brunei Darussalam. So those of you who do not know where Brunei is right there. The pointer doesn't seem to be working though. Anyway, so the Brunei is right there in the Borneo Island. Borneo Island consists of 3 countries, Indonesia, Brunei, and Malaysia. So, so Brunei is a tiny part of the Borneo Island. And so Kalimantan state of Indonesia, Sarawak and Sabah state of Malaysia, and Brunei. So these 3 countries constitute the Borneo Island. And it's a small country with 450,000 population. So the Sultan of Brunei is very rich and famous, and he had been to India for the Republic Day parade when all the ASEAN country heads were invited. So, so this is how the procession goes on in the country whenever there is some royal wedding or some function. So this is how they travel in the gold-plated vehicle with the Queen. And that right there on the right-hand side, among the rich, green rainforest, is his palace, which has about 1,000 rooms. So now some quick facts about University Brunei Darussalam, and we are 298 in the QS World University Rankings, and we are 100th among the Asian University Rankings, and among in the Times University Rankings, in 2020 we were in the top 500s, and we have 10 academic faculties and 7 research institutes in the university. So our research niche areas include cancer research, including palliative care, cardiovascular and cerebrovascular diseases, occupational medicine and health, international health professional education, COVID-19 related research, and precision genomic medicine. So introductory disclosure slide. Neither I nor my immediate family have any financial interest that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. So coming to the topic, so implant stability. So stability of implant has a crucial role in achieving and maintaining osseointegration, which is a direct structural and functional contact between the surrounding bone and surface of load-carrying implant. And the achievement and maintenance of this implant stability are the prerequisites for a successful clinical outcome. Now coming to primary stability. Primary stability of an implant comes from its mechanical engagement with cortical bone, and it is affected by quality and quantity of the bone that the implant is inserted into, the surgical procedure, length, diameter, and form of the implant. Whereas secondary stability is developed from regeneration and remodeling of the bone, and tissue around the implant after insertion, but it is affected by the primary stability, bone formation, and remodeling. Thus, it is imperative to measure and quantify initial or primary stability of implants with an easy, non-invasive, and predictable test for assessing the long-term success of the implants. So it has been widely published that the key parameter for implant success is the achievement and maintenance of implant stability. But we have to monitor this implant stability during the healing period so that we can predict the success of the implant, and also if there is any if there is any complication which is developing, potential complications can be easily identified early on. So, so this information can guide the clinicians in making informed decisions about the timing of restorative procedures and the need for implant modifications. Okay? So, and stable implants are also less likely to develop peri-implantitis or require additional intervention at later stage. So to when to load the implant, also we need to check the implant stability. Also to maintain high quality in the implant treatment for your patients. So there are various methods which have been published in the literature. There can be invasive or destructive methods, or there are less invasive methods. So the invasive methods include histologic or histomorphometric analyses, tensional test, push out, pull out test, and removal torque analysis. Whereas non-invasive and non-destructive methods can, for checking the implant stability, can be radiographic analysis, surgeon's perception, cutting torque resistance while placing the implants, percussion test, perio test, and resonance frequency analysis. So I'm going to focus on resonance frequency analysis today. And so resonance frequency analysis is repeatable, objective, and non-invasive, whereas torque or tactile feeling and assessment is non-repeatable and subjective. And second stage torque test could be invasive as well. And percussion test is operator dependent and has low sensitivity. So what is resonance frequency analysis? So it involves sending magnetic pulses to a small metal rod temporarily attached to the implant. As the rod vibrates, the probe reads the frequency and translates it into a measurement unit, which is called as implant stability quotient. And the stability is presented as, if it is higher, that means the implant is more stable. So to measure this is the Austell ISQ equipment, which is available by a company called Integration Diagnostics Göteborg from Sweden. Okay, so you can use this for immediately after placement and also during the healing time. And it also helps the dentist to determine if further healing time is needed before prosthetic tooth is attached, and to identify at-risk patients with compromised bone tissue or other risk factors. How does it work? So magnetic pulses excite the smart peg attached to the implant. So that's the smart peg which is screwed onto the implant. And these smart pegs are implant specific. For every company, the Austell company develops, for any company implant, this Austell company will develop a smart peg which can be screwed into the implant. And so the vibration frequency of the smart peg is measured. So more stable the implant, the higher will be the implant stability quotient. Now another thing for overdentures. So my topic is for the device which is used for measuring the stability of single piece implants for overdentures. So now it is also important for us to know whether we should use a conventional dental implant, narrow dental implant, or mini dental implant for rehabilitation of the overdentures. So basically, it starts with patient preferences, first thing. Second, it is also the systemic and oral health status of the patient. Then third, the oral peculiarities such as the anatomical conditions like bone quality, quantity, and shape of the alveolar ridge and skeletal class. And also thickness and health of the oral mucosa. For example, if the patient has denture stomatitis or candidiasis, has predisposition to developing candidiasis, and also the available prosthetic restorative space such as the vertical dimension, space for abutment, attachments, and prosthetic thickness in order to prevent its fracture. So talking about the mini dental implants or the narrow diameter implants, these are frequently used for denture stabilization, utilizing multiple implants in the anterior jaws. Because they have reduced diameter, they're easy to place. So they are used more in number. For example, if you use two conventional dental implants, you can replace this with 4 mini dental implants. However, these can be immediately loaded. And so therefore, it is important to carry out the stability testing of these implants. And usually, it is used for edentulous jaws to be rehabilitated, single piece mini dental implants. However, some people may think that conventional dental implants are better or regular dental implants are better than the mini dental implants. It depends on your clinical, experience. Although, however, it has been shown that it is not important that it is only the diameter of the dental implant which is important. It is the length of the implant which is important for stability. So coming to the study that we incorporated in my PhD thesis, we did various analyses for single piece dental implant, that is a mini dental implant from 3M ESPE. And so we compared it with the regular dental implant, which is ankylose, which is also one of the premier dental implants in the market. So the aim of our study was to test the feasibility of a customized smart peg for resonance frequency measurement of a single piece mini dental implant, and to compare the primary stability of a standard and a mini dental implant in a rabbit model after 6 weeks of healing. So why 6 weeks of healing? Because 6 weeks of healing in a rabbit is equal to 4 months of healing in humans. Okay, so regarding the mini dental implants, these are usually immediately loaded. Therefore, it is very important to test the stability of these implants, and also a need to develop a customized smart peg for MDIs, because the Austell company does not produce smart pegs for stability testing of single piece implants. And so because they have smaller surface area, smaller size, so that's why it's important to conduct the stability testing. So coming to the smart pegs for this particular device, on the right we can see smart pegs. There are 2 smart pegs for a regular dental implant, and on the extreme right is the Austell device, which is used to measure the resonance frequency. And so this smart peg was taken into account, and we also came up with a customized smart peg for our mini dental implants, which was actually considered as a novel invention, and it first of its kind for measuring implant stability quotient for these single piece implants. So, so this is how the smart peg for our implant looked like. The conventional smart peg, which is attached on top of the assembly. So this one has assembly which fits onto it. Has a space for the ball of the implant to be inserted into it, and So this was screwed onto it. There's a small screw there, and this is the usual smart peg, which has a magnet on top of it. So for this, we used 8 New Zealand white rabbits, and the study was approved by the McGill University Animal Ethics Board. And for this, we used 16 3M MDI implants, an equal number of standard implants, which was ankylose. And so they were inserted into the tibia or femur of the rabbits and compared. So each rabbit randomly received 2 MDIs and 2 ankylose implants in each leg. And the ISQ values were measured with the help of an Austell ISQ device using custom-made smart pegs for the MDI and implant-specific smart pegs for the ankylose. The measurements were obtained at both immediately following implant placement which is for primary stability, and to measure secondary stability after 6 weeks of healing period. Each reading was taken thrice, and the average was compared using Wilcoxon matched pair signed rank tests. Okay, so this is just to show what we used for ankylose, and those were the smart pegs for the ankylose and for mini dental implants, and that was the equipment for measuring the resonance frequency. So this is just to show some pictures of the real surgery in the rabbit model. So the rabbit was anesthetized, and then we used inserted the smart peg onto the implants and measured. And this is to show the X-ray of the rabbit immediately after placement of the implants. So coming to the results part, and so here is the graph which is showing immediately after insertion and after at 6 weeks. And so with 3M MDI, it was 53.3 at insertion and 60.5 at 6 weeks. And for ankylose, it was 58.5 at insertion and 65.5 at 6 weeks. So both implant groups achieved primary and secondary stability, ISQ values, and also increased from the time of insertion to 6-week post-insertion significantly, with a p-value of less than 0.05. So what are the advantages or uses of this invention? So this it's a first of its kind smart peg to be used for stability testing of single piece MDIs, or other MDIs can also be used. We can also have a customized smart peg for other MDIs or NDIs. And it also enables dentists to measure the stability of single piece dental implants. And the potential users are oral implantologists and companies who are manufacturing resonance frequency equipment, like, for example, Austell. And this product has an immense market potential, as these implants are usually immediately loaded. So therefore, it is important to measure their primary and secondary stability. So, and there are no other published reports of this particular smart peg in the literature for ISQ measurement. So in conclusion, the new custom-made smart peg is suitable for measuring implant stability quotient of 3M MDIs, and the primary stability of 3M MDI was similar to the primary stability attained by standard implants in rabbit tibia. So we also published this study in 2017, and I have not seen any study so far in this field. But however, more than 130 articles have been published validating the concept of resonance frequency analysis for measurement of stability of implants. We have also filed a patent in Brunei, and so this is the letter that we got from the patent office, and so this has been already applied, and we are still waiting for the results from the patent office. And so that was the end of my presentation. And I also want to highlight the scholarships for the students that we have in our university. So please take a picture if you're interested, or you can Google it up in the website of University of Brunei Darussalam and Institute of Health Sciences. And to find a supervisor, you can go for PhDs. We give scholarships, and we also have postdoctoral scholarships for fellowship scheme in our university, and you can find a supervisor. You can discuss your proposal with your potential supervisor, and they pay handsomely. They pay very well, and then that can be a stepping stone for your further, progress in any of the other, to go to any other country as well, or get absorbed there as a faculty member. So I'll be happy to take questions. Thank you very much for patient hearing.
Thank you, Dr. Jagjit, for an excellent presentation. Is open to questions, and at the outset, let me thank our Honorable Secretary General of ISDR for having sat through the entire presentation. It's lunch hour, most of the people have gone. Sir is here, and he's eagerly listened to the entire presentation. Any questions that the audience may have? This is the time for it. Dr. Shamoon. Can the mic be handed?
Yeah. Yes, so for conventional implants, I think I'll just repeat the question. So he's saying that these are available for conventional implants or only the mini implants. So this study has been done only for the mini dental implants. Conventional implants, you mean the ones with the ball attachment, or?
Exactly, yeah, the two-piece.
Yes, so the two-piece ones, it's easy to measure because provide you the smart peg, because you don't have to attach the ball attachment, and you can measure with
I got it. This
yeah, so
single
single piece
difficult.
implants is the
That's the
problem,
reason.
because
Fine.
you can't insert the smart peg, you can't screw it in, and the hostel does not provide it. So therefore, we customized and we made our own smart peg to measure the stability. So for this study, actually this study was done as a doctoral study. So therefore, there were 4 analyses. We did histomorphometric analyses. We also did resonance frequency analysis. We did a cell culture study, and we did a nanoindentation analysis. So I have presented only one part of it, which is resonance frequency analysis. It is non-invasive. There is no euthanasia required for the rabbits. So this is, I think this can be taken up as a human study in the future.
Okay, thank you.
Yeah.
Yeah, thank you, sir. It's a very good presentation. And as we are moving towards immediate loading, as far as implant is concerned, I think this study will definitely carry a lot of importance. I have only one doubt to ask, sir. Probably you have mentioned some quotient value, that initial values. So probably what will be the value wherein we should not go for immediate loading?
Okay. I think that is difficult to predict. That's why we used a standard implant to compare. However, for the you need to compare, and you need to do more studies to validate the implant stability quotient for in humans for the single piece implants. So therefore, we have to still do more research to come up with a value, to that this is how it should be. It should not go below this, and then only we can do immediate loading. So therefore, it is very important. You cannot just blindly with just your own perception. You have to have some kind of objectivity attached to the immediate loading with resonance frequency analysis, that yes, so this is the value that we can use. So this was an animal study, so we need to do human studies and validate the ISQ value. However, this is just the start, and I think it can be taken up by the younger researchers. So, and to because it has to be customized for each implant. So the implant that I used, it has a different, assembly, whereas another implant company may have a different diameter, different ball configuration. So you have to kind of customize it for each implant.
It's just a comment. Lambodharan's question was good. That was a very valid question for clinical translation. But my view is, I am not a very experienced implantologist. But what I find, the bone texture is different for everybody. So his studies on rabbit, even for human being,
Yes.
when the mandible is different, the maxilla is different. So suppose you take basal implant, it is bicortical, it engages well, so stability is better. Suppose you take any other implant, I have experienced different type of bone texture for every patient. Imagine if the maxilla is soft, you cannot take stability, the purchase is so bad, even a normal screw will not stay. What do you say, Bhagiraj? I'm sure Bhagiraj will accept with me. Agree with me, no? So every bone is different, first point. Then every implant is different. Then still we have not come to the human study.
Yes, yes.
But it's, as Lambodharan said,
Yes.
it's a very, very important study. If you give us the validation that this can be loaded, then we will load it. Thank
Yes, I agree. I mean, you have to also, use your own clinical experience and then, see if that, if with your clinical experience as well, you can validate yourself as well. I mean, it's just because we are researchers, even when we are doing clinical applications of any study, isn't it? So whatever we are doing every day, we learn from it, isn't it? And so you're right, and it can vary between the patients, and so these implants are usually immediately loaded, right? So I think it's important to have some kind of objectivity attached to it by using the resonance frequency analysis.
Thank you, Dr. Jagjit. And on behalf of the Honorable Secretary General of Indian Society of Dental Research and the organizing committee, personally myself as the organizing chairman of this conference, we'd like to personally thank you for having come all the way from Brunei and added to the, the content of our conference by presenting true and genuine research, which I'm sure will inspire the next generation to continue in this thing with the same research topic onto newer avenues. And that's what the whole objective of the conference is, as the Secretary General said in his speech during the inauguration. Thank you so much.
Yeah, thank you so much, Jagjit sir. It was an eye-opening presentation, sir. And I call upon Alex Mathew sir and Lambodharan sir to give away the memento to the Jagjit sir. Now I like to call upon Shyam sir and Sudeep sir and as well as the SM Balaji sir to give away the memento to the Alex Mathew sir and Lambodharan sir.
Thanks, Alex. Not all.
It's a big honor to get this memento right. Thank you, sir. Thank you. Thank you, sir. It's all ideas. All ideas. Thank you, sir. My cousin was also that's like suddenly saw he became He's in CSI. I'm in Meenakshi.
Now his son is also graduate. He's also professor. Ramchandra. Same name, sir. My father is my father.
Now the session is open for the lunch and we will be returned back to by 2 p.m. Thank you.